have back pain, I have knee pain, I have any pain in the body. It can be as simple as you're growing older, Tylenol, NSAIDs, boom, you're done. Well, if you do imaging and it does show some pathology by way of disc bulge, by way of facet problem, which is the bones of the back that is arthritic, he is correct, and I do this, by the way. You can then go in and while, just like doctor said, while you may not be able to do much for the arthritis that the patient may have in their back, you can go in and ablate the nerve that is supplying the joint, that is making the patient feel the pain. So they feel the pain because there's a nerve that connects the joint to the brain. You can't fix the arthritis just because you can, just because. However, you can go in and sever the nerve using ablation, just like Dr. Kiki said. You put a probe in, you connect it to the machine, you burn it off. So the arthritis is there, they just won't feel the pain. But that is escalating the treatment method based on what you're finding in terms of the severity of the patient's pathology. So if you do that a bunch of times and it's still worsening with an obvious risk to the spinal cord, then you need to do surgery. Because not doing surgery means that Jacobi will knock on your door. That's a lawsuit. That's a term in medicine.
Thank you, sirs. At least we've learned one or two things. The first thing we've learned is initially management as much as we can. It's part of the aging process. And then, as he's mentioned, as it escalates, then, there might be other procedures. We have a question here for you.
Speaker? Okay. Okay, so gotta be away from the speaker. All right, very fast. All right. My question to you guys is basically understanding the role of physical activity and how it plays a role in the wear and tear of the body over time. We talked about wear and tear at 70 years old. We've seen people like Cristiano Ronaldo, for example. Obviously, he's not 70, but over time, he's been able to maintain a certain type of physique. And then what are the things that contribute to the reduction or aggravation of that wear and tear? And what role does physical activity or exercise play in that? Thank you.
Thank you. That's a great question. So we'll just throw it open to any of the docs in the house.
So there are two columns. There's a difference between a Cristiano Ronaldo who is physically active, does exercises. And by the way, he has, how will I put this? He has a skilled or a way to do his exercises to improve his performance. It's different from somebody else who lays bricks like, okay, a 17-year-old Cristiano Ronaldo and a 17-year-old bricklayer. Fast forward 20 years later, Cristiano Ronaldo is 37 years old, and he's still playing soccer very well. Well, a 37-year-old bricklayer 20 years later has back pain and is in a lot of problems. Well, there's a difference because while Cristiano Ronaldo has a regimen to follow, including diet and exercise, the guy that lays tar all day, bricklaying all day, I'm not saying you can't be a bricklayer, I'm just saying, people that I see in the clinic, that is not a structured regimen physical activity. So there is data, science behind what Cristiano Ronaldo is doing, coupled with nutrition. Bricklaying is just a job. The same reason why people that do heavy lifting on the job, they carry heavy weights on the job, they have a disc bulge, and then there's a problem. Cristiano Ronaldo has a way to do all his activity without necessarily having a disc bulge. Now, it doesn't mean he won't have issues all through his life too, but those are injuries that are sustained while doing what he's doing. So that is the difference between, now, a 70-year-old Cristiano Ronaldo, though, eventually, such an activity might catch up with him. Case in point, we see a lot of boxers who are very active in their days, i.e. Muhammad Ali, and then much more later in life, it still catches up with everybody's body. It's just that while a Cristiano Ronaldo will have a structured regimen backed with science and nutrition, somebody else who is like a bricklayer or people that do hard jobs, they have the wear and tear. But everybody eventually will have wear and tear. It's just how soon and how fast. That's the difference. So needless to say, I want to be in Cristiano Ronaldo's camp. So you're correct.
If I can just add to
okay.
that. We were all like kind of having some fun over playing tennis, ping pong, and pool. Everyone needs some form of exercise, but make it structured. I mean, we're not going to be as structured as Ronaldo. That's the example. These are like conditioned athletes that are paid to do what they're doing. But if you're going to engage in any kind of lifestyle modification, which includes diet and exercise, please talk to your physician, your primary care physician, and have a structured training program. You can join a gym. Please don't go and just start lifting weights on your own without any like trainer to assist you, because you might hurt yourself in the process.
Thank you. Okay, I think we have 3 questions waiting, so we'll move.
Yeah, praise the Lord. My name is Victor Olusegun. Thank God my wife is not here today. She complains mostly about my weight sometimes. Now the question is that which one is better? Is it to go to gym or to apply the process of fasting? Because I read it online that sometimes you go to a gym, it doesn't reduce your weight or this thing. But if you do maybe twice or thrice fasting every week, it reduces. Just want to ask which one is better.
Thank you. Great question.
The short answer is all of the above. You need exercise. You need to watch what you eat. And one of the things that I had to learn, too, coming from home, is that our diet, our food is great, but it can also be unhealthy. And I just had to learn what to eat. You can't eat pounded yam every day, as much as I love it. And rice. These are the carbs are the things that pack on the weight. And so and in doing the diet, from my own standpoint, what other complications are there? You have hypertension, you have diabetes, because the weight is also a risk factor for developing these metabolic conditions like diabetes. So a diet that is rich in vegetables, leafy green vegetables, lean protein like chicken, turkey, don't fry it. We love fried food. Don't fry. And if you're going to do carbs, do more of, any kind of beans, because it's rich in fiber too. But the rice, which we all love, is the thing that, I have to fight that battle myself to train myself, because I grew up eating rice. The other half of it is the exercise. So they go hand in hand. Diet goes hand in hand with exercise. If you choose to do one or the other, yeah, you may get some success, but it doesn't work as well. You have to do both. And like I said earlier, don't just blindly start some kind of exercise. Talk to a trainer. Talk to your doctor, talk to a trainer. No doctor will tell you, oh, you shouldn't exercise at all, unless you have some other condition, some underlying condition like a heart condition. Okay?
So I think that's exactly what I was going to say is you can't substitute one for the other. Dieting is good, but exercise is also equally important. Because I think a lot of times, a lot of people think about exercise just for weight loss, but exercise is not just about weight loss. When you exercise, there are physiological changes that take place in your cardiovascular system, in your heart, your blood vessels that actually could improve the health of your heart and how your blood flows through your body and keep you sustained over time. So it's important to exercise to get your heart rate going. It's important to have cardio, not just for the weight loss, but because of the physiological effects that it has on your system.
We have a comment here by Dr. Jide.
Okay, so just talking about dietary modification, right? I know that we often talk about, reducing salt, blah, blah, blah. But one of the things I've been paying attention to personally, other things that we eat being in America, right? Because sometimes you will notice, I mean, a lot of us were slimmer than this in Nigeria before we came here. You know, the natural thing you would think about is, you know, now you are relaxed and everything. But not quite. Because when I was doing my master's program at UGA, I did a project at a chicken farm in Pendergrass. And everything was so calculated. In 3 months, they will hatch an egg and grow it up to a slaughterable age with antibiotics and steroids. And they will move it, and that thing is on clockwork. If it doesn't follow that pattern, they lose money. Now, guess where all of that goes into? It goes into our bodies, right? The antibiotics, the steroids, and every other thing. Now, including everything else we eat, bread, blah, blah, blah. There are preservatives because people are commercial and they have to make their money, right? So, going back to Cristiano Ronaldo's, analogy that he gave. If you remember during the World Cup, Ronaldo did something, right, when he came for a press conference. He took the 2 cans of Coke that was on the table at the press conference, put it aside, and then he said, aqua, right? He said agua, which is, Latin for water, like drink water. Personally, it's a lifestyle modification that I started to imbibe at the start of this year. I used to drink Coke a lot. I'm talking about 2 cans or 3 cans a day, right? And, all of that goes somewhere, and it contributes to the metabolic damage that goes on in our bodies, in our system. So, again, everything else, will naturally make a stop by at Burger King. You buy, double stacker with fries and with Coke, right? And some of us eat that on a daily basis. We need to be intentional. The results may not be now, but we're not getting younger, right?
Thank you, sir. Because of time, we're going to move on. We have a few other questions, so this is a quick one.
Yeah, praise the Lord. Yeah, my question is the direction of this pain relief. Yeah, most times I do have pains. If I take my opportunity to take like our extra Panadol in Nigeria, I'll be fine. But here, if I take ibuprofen or Tylenol, I don't get any result. I don't know what you can recommend for me. I can't be ordering for drugs every day from Nigeria. Thank you so much.
That's a very practical question.
Is it neck pain, back pain? You didn't quite specify. Joint pain, okay. So again, if you have joint pain, the question is it just straight up, I have joint pain because I'm getting older, I have joint pain because I worked too much, I have joint pain because I did too much activity? Or is it that you have joint pain because you actually have a real medical issue, i.e. rheumatoid arthritis, i.e. lupus, i.e. SLE, i.e. dermatomyositis? So I'm just saying. Okay, So, I apologize for that. So
Temper justice with mercy.
Yeah. But the reason why I'm saying that is because the importance of self-consciousness. Because if you have pain, it is not just okay to assume it is this pain. It's also a good thing to know that, God forbid, it could be something else, and it would be nice to look at. Assume it's just your day-to-day pain. You talked about taking paracetamol from Nigeria. It's not working. Well, you're in America now. I don't encourage my patient to take NSAIDs. By that I mean ibuprofen, Aleve, naproxen. While it's okay to take them once in a while, I discourage them taking it long-term, consistently on a chronic level, because of the potential effect it may have on the kidneys. People come into the hospital all the time with acute kidney failure, and one of the reasons is because they've been popping ibuprofen. So I still say that take the Tylenol. Now you say the American Tylenol does not work. Well, not sure. there's extra strength Tylenol that you can take. But again, be very careful not to take too much of Tylenol because of liver. But if you take the extra strength Tylenol and you don't think you're getting the relief you need, then you need to see a doctor. Because there is no other pain medicine you can take anyway without having to see a doctor. Because if you're going to escalate the pain medicine, you'll be talking about Tylenol number 3, then you need a prescription for that. So I would say take your regular Tylenol, and if the pain is unabating, then see a doctor.
If I may add to what Dr. Lekon said, paracetamol is the same thing as Tylenol. It's just called a different name in Nigeria. So, and if you're taking the extra strength Tylenol, 500 milligrams, you can take 2 at a time. But please don't take it as needed. Don't take it if you don't need it. And you cannot take more than 6 tablets a day. But please, 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 the bottom line is go and see your primary care physician.
So the rule of thumb, well, it's a standard medical practice. You don't want to take more than 3 grams of Tylenol per day, which is 500 times 6, 3,000 milligrams, which is equals to 3 grams. So you don't want to take more than 3 grams of Tylenol per day. Now, there are some guidelines that says that if you're an alcoholic, and I want to believe there's none amongst us, the cutoff is 3 grams. If you're a non-alcoholic, the cutoff is 4 grams. But the lower, it's always good to use the safer margin. So I tell my patients, not more than 6 tablets per day, just like the doctor said.
Right, thank you. You have one more question?
Mine is 2 parts. Okay, I'll start with the one. I work as an IT person, and over time, my posture seemed to have affected, leading to me having back pain. So what is the easiest way to, first of all, resolve this? And my second question starts from the exercise. I have really tried, though. I will lose weight everywhere, but the 1 pack I have, that's where the problem is. So how do I do to resolve that 1 pack?
I think a lot of men here can really relate to that because we talked about it when we were playing the ping pong. So it would be very great if you could have any insight. Thank you.
So the answer to the first question would seem to me like it's related to your posture based on what you just said right now. You're an IT person, you're always sitting down, doing your work, and it will seem like you develop pain because of the posture. So you always, in medicine, I haven't seen the patient, common things occur commonly, like we say in medicine. You always want to start with the simple solution based on what the patient is complaining about. And as you find more, God forbid, worsening scenario, then you have to escalate your treatment to care for the patient. So adjusting your posture, the solution to the back pain you are experiencing might just be as simple as adjusting your posture based on what you just said right now. You could use a back brace. You could look for a chair that will, match the curvature of your back, And there are tables now whereby you can actually stand as you type. That way you're not on your chair all day. You can take intermittent breaks and walk around. Now, like I tell my patients, you can also do what is called back muscle strengthening exercises. Because the stronger the back muscles are, the better they are able to support the spine. Because when we stand, think about it. This is the spine. You have this is the sacrum. This is the sacrum. You have the hip bone here, hip bone here. The entire weight of the tummy lies here. So if the muscles can support, because the muscles are attached to the spine, so the stronger the muscles of the back are, the more support they can afford the back. And there are exercises you can do to help you in that regard. So back muscle exercises that will strengthen the muscles and better posture, preferably if you can do a back brace, it could help. And what was the second question? The 1 pack. So
Iron Man is there to help you.
I answered it. Yes, that's true. Yeah. So if you strengthen the back muscles, it will pull your, because if the part goes forward, if the back muscles are weak, it pulls it with it.
Okay, we're going to take the next question.
Okay. Thank you, guys. I want to say thank you for this panel. It's very educative, and I wish there were more men here who could take advantage of things that we consider so simple, but yet we hear them every day, and we can change our lives. I want to go in a slightly different direction, talk about blood pressure. When I was growing up, the knowledge I had was that blood pressure was something for the older folks. At that time, I didn't think I would get older. Here I am today. But it seems like that information has changed. One of my sons suddenly started experiencing higher blood pressure. I have a nephew who's 20-something who is now on pills for blood pressure. So it's beyond age. I want to ask your best advice. For those who are lucky enough not to have, started experiencing the negative part of it. And then I'm also concerned about the spectrum. It seems like, there are different degrees of severity now. What should we do at different phases when we notice, some of these changes that are negative? And I say this because here is a silent killer because it has no obvious symptoms. So you see people walking around and they drop dead and they say, oh, they had a high blood pressure. It's something that is critical for men, especially as busy as we are, running around to try to put food on the table. We need to take care of this body. Thank you.
Yeah, I'll actually start with a personal experience. You're exactly right. Blood pressure is not a thing that affects just older people. It can affect, younger people, especially males. And I personally started having high blood pressure, at a young age. I still consider myself as, pretty young. But some years ago, I started experiencing high blood pressure. And, for me, the initial symptom I noticed was I started having a lot of headaches. So what came to my mind was, okay, Kiki, start checking your blood pressure, more frequently. And I noticed it was high, probably because of stress. So at that time, at the range for which it was, what I did was I modified my lifestyle a bit. And really, the only thing I really included in my lifestyle, I watched my diet, but I started exercising a whole lot more. And that brought it under control. And today, I'm not on blood pressure medications, but because I was able to carry out some lifestyle modifications when I noticed I was in that pre-hypertension phase. So I think that's something that young people, especially young men, need to be aware of is, if you notice your blood, in the first place, you should be checking your blood pressure frequently. But even before it gets to the stage of medications, being on antihypertensives, exercise, and that's why we keep talking about exercise. It's so important. Exercise is beyond weight loss. It regulates your entire cardiovascular system and can actually help maintain your blood pressure in a good state. But now there's certain other factors that people have, other risk factors that predispose them to having high blood pressure that even beyond exercise, they may get to the point where they require medications. It's important that if it's at that stage, you start early before there is you experience what is called end organ damage and you begin to damage a lot of your organs. So the most important thing is monitoring it, starting early, being aware of what's going on and taking action.
So if I can just add to what he said. So it is true that high blood pressure is more prevalent in older age group as compared to younger age group. And the reason is very simple. The vessels of the older age group is thicker. As we grow older, everything ages. Our blood vessels are thicker as we grow older. So the heart would need to pump harder to pump blood through our body. And that's why pressure goes up. So high blood pressure is normal for older people, and there is nothing unusual about that. Now, for the younger folks, the blood vessels softer, the muscles are softer, so the pressure shouldn't be high. Now, that doesn't mean that younger folks can't have high blood pressure. And if a younger guy or girl comes to a doctor's clinic with a high blood pressure, more often than not, there is usually a secondary reason why they have that. Because the commonest cause of high blood pressure is what I just talked about in older age people. So a 27-year-old person comes, a 20-year-old person comes with high blood pressure, it is more likely for a doctor to look for a secondary cause, unfortunately. Do they have a renal stenosis? Do they have something else going on apart from taking blood, vessel? If there is none, and everything is normal, then what Kiki talked about would be the first thing to do, because they're young. They have no reason being, flirting with high blood pressure at the young age. You want to do diet, lifestyle modification, exercise. But if you do everything and nothing works, they have to be on a blood pressure medicine. And they have to be on it because that is the right thing to do. Now, it's different from a 60-year-old person or a 50-year-old person or a 55-year-old person that comes in. Now, you could still try lifestyle modification. One could still try lifestyle modification for the aged person, I would say 50 and above. But if that doesn't work, just put them on the medicine. Now, it may take a while to walk through the kind of medicine that would work for such a person. And I tell people, please, please, I beg, I have high blood pressure. I take amlodipine 10 milligrams PO daily. I take atenolol 50 milligrams PO daily. I found out 5, 6, 7 years ago. I've been on my pill every morning, 1 pill a day, each. Boom, that's it, I'm done. I check my blood pressure once a week. It's always been 120/80. I'm good. I tell my patients, just take your blood pressure medicine, you live to be 100. That's it. No gimmick about it. So the idea that people take blood pressure medicine for a while and stop because it's normal, and then 6 months later, they have a stroke. I see it all the time in the hospital. When I go around in the hospital, or they take their blood pressure medicine, they come in, their creatinine is 1.0, kidney is normal, and then they get discharged from the hospital, and then 1 year later, you see the same patient in the hospital rounding. Well, you remember, and the creatinine now is 4.0. They have to be on dialysis. Why? Because they're not compliant. Why? So I tell people, particularly in the older age group, please take your medicine, you will be fine, nothing is going to happen. The same thing with diabetes. You check your blood sugar, if it's high, you do the standard guideline treatment, testing, fasting blood sugar. If you have high blood sugar, take your diabetic medicine, you will be fine. You live to be 100. That's what I tell my patient. And they laugh at that. And, yeah, you live to be 100. So those are the spectrum, like Oga said about, younger people shouldn't have it. You look for secondary causes. If you can't find, they're normal, put them on medicine. Elderly patients, you may choose to look for secondary causes if you want, but we all know that thickened blood vessel is the reason why pressure is high. Put them on medicine, and then everything should be fine. Thank you.
We have to start moving on. There are a few other questions.
Just to follow up, please. Kiki talked about diet and lifestyle changes, the commonest things to do, exercise. But it seems to me like there's some specific type of exercises and some specific type of dieting that may be required, And then I'm also concerned about the situation where it seems like even though you're taking blood pressure medication, but over time you still see it trending up and they may need to increase the dosage. What is responsible for that?
Okay.
No, those are two questions, please,
So
for clarifying.
the
Thank
first
you.
question is lifestyle modification, diet and exercise. I believe your question was what kind of exercise would help? Anything that cardiovascular intensity, And again, like I said, talk to your primary care physician. They know you best. You need like some at least moderate intensity exercise. Now, I don't know if you are just a starter, you don't do any exercise at all. You may want to start with just taking a walk, 30 minutes every day, 5 days a week. That's 150 minutes of just walking, brisk walk. Okay? Now, of course, as we grow older, as we've been talking about, there are other things that come in, such as developing arthritis. You can't go jogging. You will hurt your knees. That's why we start at that level. And if you talk to your physician, they will tell you what kind of exercises they think is what level is appropriate for you. Now, the exercise alone by itself will not do it. The diet by itself will not do it. If you do both, you have a better chance. However, even that may not be enough. It's called the first line. The lifestyle modification is the first line, always. But if that is not sufficient, then we add on medications. Now, the other question you asked was, what was that again? Specific diet, right. So for hypertension, there's something called the dietary approach to stopping hypertension, DASH. You can look that up. There are other things like the Mediterranean diet. You can look all of those up. But again, it comes down to talking to your physician, having a plan with them. What we call decision making, where you sit down and you talk to your doctor. We no longer practice medicine by telling our patients, thou shalt not, or thou shalt do this. You discuss, just have a conversation, just like we're having now, and tell your doctor, I can't do this or I can't do that. No, that one is acceptable. They will listen to you. Now, specific exercises, like I said, talk to your doctor. Diet, talk to your doctor about that. But those are some of the things. If hypertension is the problem, yeah, the DASH, Mediterranean. If diabetes is the problem, then you want to do, the simplest thing to do is the plate method. You can Google that, it's pictorial. You can see how to eat. Where there's a plate, you cut the plate in a half, one half, vegetables, leafy green vegetables. The other half you divide into a quarter and a quarter. Carbohydrates, complex carbohydrates, and lean protein. That's the summary of that. You know, there is no simple way to do lifestyle modification. You just have to stay at it. And one of the things I hear a lot is, I don't feel anything. Why are you putting me on medication? But your blood pressure is systolic over 200. You won't feel anything until the stroke happens. And then you won't feel anything after the stroke. That's the problem.
So just to make a comment quickly, you may, like Brother said, you can have a high blood pressure and they put you on one medicine, the pressure goes up, your physician puts you on a second medicine, the pressure goes up, they put you on a third medicine. It is an unfortunate situation, but like I tell, again, like when I see a patient in the hospital, in the emergency room and all that, it is still the job of the primary care physician or whoever is managing the patient to look for the most appropriate medication regimen and combination to keep the patient's blood pressure down. Because not to do that almost eventually ends up in some kind of end organ damage, i.e. stroke, i.e. blindness, i.e. heart failure, i.e. heart attack, i.e. kidney failure. You know, so, and there may be other issues going on. An individual may have developed a high blood pressure because they're getting older. Well, at some point in time, during the course of their life, maybe they developed the renal artery stenosis, and that is now complicating, you know, treatment of the blood pressure. So it will be incumbent upon the patient's primary care physician to then look for secondary reasons why the patient may be having uncontrolled high blood pressure, in addition to the fact that they're getting older.
Okay, a few quick ones.
What happened when a man starts having constant urination, especially at night? Like you gotta go, like maybe 3-4 times at night. Is that a sign of prostate or what? And what is the remedy?
So constant urination at night. So it depends on the age. Again, BPH, which is just as simple as enlarged prostate, typically does not happen in young age. It shouldn't. Young person shouldn't have BPH. Happens in much older age. So I am assuming that the question is designed for people, I would say above 50, right? I'm assuming that's, so if a man is having frequent urination at night, well, the question is there burning? Is there pain? Is there fever? Those three questions have to be, answered. Is there burning when you go pee? Is there pain when you go pee? Is there fever? Is there blood? So those are the questions you also have to ask, when you're having frequent urination. And of course, you need to see a doctor. So if a man is having frequent urination, it could potentially be a sign of BPH, because BPH just means that the prostate is and is obstructing the urethra, such that when you go pee, you don't empty your bladder. And then you go to bed, and then the bladder fills up sooner than later, and then you gotta go pee again. Well, you're not able to still empty your bladder completely because there is BPH. It's obstructing the outflow of the urine, and that goes on and on. And yeah, you need to see a doctor. But that would be the first thing any primary care physician will think about. Of course, you can think of UTI, urinary tract infection. UTI is less common in men just because the distance between the penile orifice to the bladder is longer. And that's the simple reason why it's less common in men. But it's not impossible. Okay? That's number two. Number three, STD can be the reason why such an individual is having frequent urination. So to rule out STD, to rule out UTI, to rule out BPH, benign prostate hypertrophy, you need to see a doctor. But those are the possibilities, Common things occur commonly in medicine.
So if I may add to that, please see your doctor. What we do, and your primary care physician. Primary care physicians, and I'm not saying this because I'm one. Primary care physicians are, if you watch football, American football, primary care physicians are the quarterback of your healthcare. Once the ball is snapped, it goes to the quarterback. The quarterback decides if it's a running play, if he's going to pass it, which way they're going to pass the ball. Your primary care physician plays a huge role in your health. What we do is we score. There's a scoring system, the AUA system, your symptoms, because it's really a clinical diagnosis. Well, it depends on what you tell your doctor. I'm waking up 4 times a night to pee. Well, is it any of these other things? And we rule those out. Then we score. Depending on that score, we'll decide, okay, we'll start a medication. Okay? And they put people on medications, and if it's not controlled, we also check the prostate-specific antigen, which is not specific really for BPH. If you need to be referred to a urologist to have a procedure done, we do that. So it will all depend on how you respond to treatment. But please see your primary care physician.
Could also be diabetes insipidus, potentially.
That is very correct. Yeah. It could also be diabetes, unfortunately.
Just checking your blood sugar, if it's above 200 at any point in time, checking your A1C. And I'm hoping everyone sees their primary care physician at least once a year. They get screened for diabetes, because we haven't talked about screening yet, which is prevention, like they say, is better than cure, right?
All right. Thank you so much. I'm not sure what is wrong with men, though. We don't like seeing doctors, right? And I think it's a common thing that I've seen all around. I'm in IT myself, and there's something we do. We ask for the 5 whys when something happens, when you're trying to troubleshoot something. Why? It's something, okay, why? One of the things that I have done, and I'm being intentional about, is actually giving myself peace of mind. We are constantly under pressure as men, and we tend to forget all these things. I think Iki was mentioning the fact that pressure of life, right? Unknowingly, right? You're thinking. pressure to fix this, pressure to meet this, pressure to do that, and one way or the other, those kind of things affect our lives eventually, resulting into medical problem, right, that we're not even thinking. But my question is this, does hereditary play a role? Because sometimes you see people, you think just because you are slim, you're healthy, that's wrong, right? Does hereditary play a role in, because, for example, at least I tried to do my, the yearly check once a year, check all the vitals, check all the things, take regular blood pressure measurement all the time. But I've seen times when I'm under serious pressure at work to deliver, right, that my pressure could just go up, right? So, but my question is just, does hereditary play a role in, our physiology in life? Thanks.
I think I can start with that one. So, yes, a lot of, especially metabolic disorders, are hereditary in nature. And that's why it's always very important to know your family history and know the medical conditions that exist in your family history. And it goes along with everything we've said here today is, I think I'll say number one, be vigilant. If you know your family history, you be vigilant about the conditions that exist in your family and start monitoring yourself early enough. The key thing is getting ahead of the game, getting ahead of the situation. And depending on where it is, like getting in touch with a primary care physician early enough to monitor your situation, monitor your blood values. And if you're at a state where at that point in time is lifestyle modifications, then that's it. But if you need to be on medications, then you need to be on medications. And if that needs to start earlier, then it should start earlier, and you have to play a role of being compliant. So I think knowing your family history, where that helps is you know what exists in your family and you're looking out for it early on. And not just like the common metabolic disorders like hypertension, cholesterol, and all that. Sometimes there are other certain scenarios, even cancers, that exist within families, and it's important to get screened early to get ahead of it.
So yeah, hereditary does play a role, and just like Kiki said, it is good for us all to have a clear understanding of our family history. Because you see a slim person comes into the office and you do a routine blood work on them and their cholesterol is high. Well, I'm slim, don't matter. Well, you've come to find out that there's a history of hypercholesterolemia in the family. In fact, the guy's father actually had an MI, myocardial infarction, heart attack, due to high cholesterol. So he comes in here now, he's a slim guy, but his cholesterol is high. So indeed, yes, hereditary does play a role. The important thing though, like Kiki said, is for us all to be vigilant. At some point in time as we grow older, I mean, for example, I have a primary care physician. I see my primary care physician every year. Myself and my wife, we do fasting blood sugar, we do blood pressure, we do blood work every single year. Obviously at a much younger age, I mean, 20, 21, 22, most of us probably don't do it. We should, but we don't do that. But as we grow older in our 30s into our 40s, yes, we should. Every single one of us in this room should have a primary care physician. And every single one of us in this room, at the minimum, should do an annual checkup once a year to check all this stuff.
Thank you. Going back to pain, how long can you feel a pain before you start using pain reliever? And how long can you take a pain reliever before seeing a doctor?
Oh, great question. Okay, so rule of thumb, if you have pain, some of us, our pain threshold is different. Some people, they have pain threshold of this level, and then hell is coming to the house. Some people, their pain threshold is here. But at any time that whatever pain an individual has, it's affecting what we call independent activities, independent daily activities, i.e., you wake up in the morning, you You want to have your bath, you want to eat your food, have breakfast, you want to drive to work, you want to do your regular job. At any point in time that the pain an individual is having is beginning to affect, their independent daily activity, you should see a doctor, because it's beginning to affect your quality of life, because it's now taking your independence away from you. The things you used to do unconsciously, you now have to make conscious effort to do them. Of course, the only over-the-counter medicine you can take is Tylenol or NSAIDs. And NSAIDs, I mean ibuprofen, naproxen, and what have you. I always say Tylenol because of the reasons I spoke about earlier. Long-term kidney damage because you're on NSAIDs. You take Tylenol. Now, how long should you take that? Well, if you take your Tylenol for a day, maximum 2-3 days, and it's not helping, you should see a pain doctor. And quite honestly, if the back pain is so bad, you probably see a doctor even by the time you take Tylenol for a day or two, you'll be seeing a doctor.
Okay, thank you for talking about the pain, the level of pain threshold. I have a very high level of pain threshold. I can sleep with serious headache, as in my head is blowing up, and I'll still lay there and I'll sleep and snore. If you blow air to my wife, she's going to feel pain. She has a very, very low pain threshold. Now, I need to ask, if the pain is affecting your daily activities, is it possible that the pain is affecting your daily activities and it's not damaging anything? Is it possible? That's one possibility. It might be affecting your daily activities. Probably you're not working very well, but I mean, you can still endure and still go ahead, right? Because you have low pain threshold, right?
I get the question you're going to ask me. The question is, if I have a high threshold and I have pain and it's not affecting my daily activity, do I necessarily need to see a doctor? Well, because I do not know, I'm thankful that we're in church. Only God knows everything. We don't know. I would not advise you not to see a doctor because you just don't know. You talked about having a terrible headache. If you have a terrible headache on Monday, you're able to go to bed, wake up on Tuesday, you move on. You have a terrible headache on Tuesday, you wake up on Wednesday, you go, you're fine. Well, the following Monday, you have another terrible headache, there is a problem. Or let me not say it that way. You should have it checked because it is not normal. The normal way God made things to be is for us to wake up in the morning and do stuff, not to have headache every day, not to have migraine-like headaches every day. So I won't, because you could, one of the ways I found out I was having high blood pressure was I was having headaches. And I don't take pain medicine. I still don't take pain medicine. I was able to sleep, and then I'll be like, oh, okay, headaches, whatever. And then we're just in the procedure suite one day, and we were all playing around with blood pressure cuff, believe it or not. And that's how come I found out, hey, Dr. Henry, listen, pressure is high. What's wrong with you? And that's how I found out that I was having high blood pressure, and then I took care of myself. I'm good. So the point I'm trying to make is that if you're having headaches, if you're having pain, but it's continuing, either continuously or intermittently, but it's continuing, then I would encourage you to have it checked out.
Can I add something to that? My brother, you mentioned headache, head blowing up, and being able to sleep, and you also added snoring in your sentence. And what came into my mind immediately, you said that is obstructive sleep apnea. It's a serious condition, and if anyone thinks they snore and they stop breathing when they are sleeping, and of course you would not know, only your wife would know that, please see your doctor. You might need to have a sleep study done. It is a serious condition that has serious implications. In fact, it might make it almost impossible, if it's not treated, to control stuff like hypertension. So the beauty of what we do is that it is all connected based on what you tell us. I hear you, and I just threw that out there for everybody. If you think you
Well,
snore,
go and see your primary physician. So, but somebody actually raised the point you talked about, OSA. So I don't know if you could probably throw in a bit more, because that's also something you talked about, snoring, obstructive sleep apnea.
yes. So obstructive sleep apnea really is, well, the more common one is not the central one. It's the one where people are sleeping, they don't know this, but they quit breathing, or they breathe at a reduced rate. And what happens is that the beauty of the way God designed us is that there's an alarm center in the brain. When you're not getting oxygen into the blood, that the alarm goes off, and these people usually snore, and the way it goes is they snore, and then they stop breathing. You don't hear any snoring. It is not the snoring that is the problem. It is the not snoring that's the problem, because they are not breathing. And the alarm goes off in the head, depending on the severity, which can only be determined by a sleep study. If it happens more than, say, what we call the AHI, if it happens more than 5 times, okay, an hour, then it's graded, depending on how the severity. You may need to be put on a CPAP. It's a machine that you have to wear to sleep, and what it does is it opens up the airways by air down. And therefore, it opens up the airways, and it allows people to sleep peacefully through the night and reduce the frequency of the waking up. Because the waking up can be so frequent, depending on severity, that you really don't sleep. And the funny thing is, you won't remember it in the morning. You just wake up with a headache, feeling like you didn't sleep at all, like a truck ran over you, and you just don't feel well. And like I said earlier, it has serious implications for stuff like controlling hypertension if it is not treated.
I'll add to that. And a lot of times, things like that, it could really happen to anyone, but it's more likely to happen if someone is obese. So one way, obviously, to counter that is just obviously keeping your weight down, exercising and trying to reduce your weight. But, I think another thing I would say is, going back to what you said about headaches and pain and when is the right time, to keep it short, just because you can tolerate it doesn't mean you should not investigate it. Because I think a lot of us, especially within the African community, we're always afraid to find out. Nobody wants to hear bad news. So sometimes things are going on and people don't want to find out. They're like, it's better if I don't know. There's a saying, what I don't know wouldn't kill me. That is not true. What you don't know can kill you if you don't find out early enough. So just because you can tolerate something and you're feeling a certain way, don't say, you know what, I can handle this. Always have that high index of suspicion. Talk to someone, talk to your primary care physician, and figure out what's going on. And by the grace of God, maybe there is nothing going on. But you'll be happier if there was something happening, you found out earlier, and something was put in place to save your life.
Okay, my name is Godwin Akiwoche. I was just talking with the professor if we'll have free consultation at the end of this. Because I would personally want to meet with Dr. Lakon. I would still want to meet with you, sir, on pain. Okay, my dad had...
By the way, yeah, free. That's fine.
Thank you, sir. My dad had prostate cancer, operated, and it lived. It's
breaking. What did you say?
Okay, I said my dad had prostate cancer, was operated, and he lived 10 years after, up to 91. So in a way, there's a history. So I have done my annual check this year. There was no trace. But I want to ask, what are the prevention measures for presenting enlarged prostate in men?
I'm not aware in the literature, so far so good. Today's date is 12th of May, right? Today is 13th of May. I am not aware in the literature that there is any preventive measure to prevent BPH, benign prostatic hypertrophy, which is the benign form. Unfortunately, the cancerous part is the adenocarcinoma of the prostate. I'm not aware there is anything you can do to prevent it. But what you can do is surveillance, which is when you go and see your family doctor. American Cancer Society will. There are different societies and they have different recommendations. You know, in fact, there are some people that would say that don't be too aggressive in checking people's PSA because what if it's elevated? What do you do with it? But believe it or not, most primary care physicians will still check everybody's PSA, particularly if you're over 50. So I would say for now, what most primary care physicians will do, myself inclusive, is to check PSA, you know, prostatic specific antigen annually, you know, and if it's normal, it's normal. That's it. Not unless you have a symptom, like we talked about earlier, whereby you are having frequent urination and then they may need to do a rectal exam to feel if the prostate is enlarged. But if the PSA is normal, it's normal. So that's what you check.
Yeah, and just to add to that, so the BPH is not really the bothersome thing because the B stands for benign. That's a totally different condition. And it doesn't mean that if you have BPH, enlargement of the prostate, that it's going to progress. In fact, it doesn't. It's not going to progress to cancer. Prostate cancer is a different thing entirely. And you said something very important in your question. You said dad had it. So the risk factors for developing prostate cancer in men is family history, age, and guess what the last one is? Black people. So virtually all of us in here right now, with the exception of one person that I can see, is at a higher risk. We all are. If you look like me, you are at a higher risk, especially if dad had it. So in such people, although the guidelines are all, they say different things, different recommendations, the USPSTF has its own recommendation, the idea is that not to screen for it. That's their recommendation. But if you have those risk factors, and you have two of them, sir, dad and black, I don't know about age, if that's a risk factor for you, but then you sit down with your doctor, they will screen you for it. They'll get a PSA. And although the PSA is not diagnostic, because the PSA can be elevated for even BPH or if you have an infection of the prostate. But if we have to look into it if it's elevated, especially if you have the history from family.
Praise the Lord. I will take doctors back to what you say about high cholesterol. Few months ago, my wife make pounded yam and egusi, and I ate it. After finishing eating, I went to bed, and I started having a chest pain, serious chest pain, and I took Tylenol. I went to work. After that, I went to the emergency room, and they couldn't find anything. They did whatever they could do, like blood work, X-ray, everything. They said they can't find anything. But I know that I'm having pain in my chest. And a few months ago in December, I was in Nigeria. I had the same chest pain. I complained to my mom, and my mom gave medicine, and I went away. And after that, the doctor referred me back to the heart doctor. He asked me to go and do tray-made test, which is I did. They can't find anything. But at the end, they said, what is causing my chest pain? I know that I'm having pain in my chest, but they can't find anything. And at the end of the day, they said, maybe I have high cholesterol, which is, I went for another blood work. They said my high cholesterol is high, and it's 3.5. I said, okay, put me on medicine. But they couldn't. My question is,
we can barely hear you up here.
my question is, what's causing my chest pain, and why doctor refused to give me medicine for my high cholesterol?
High what?
So I think it's a high cholesterol.
Oh, high cholesterol.
Yeah.
Oh, okay.
Oh, the chest pain, sir, the chest pain, so there are many, the way we think about when we see anybody with a complaint, we go through a list of possibilities, what we call the differential diagnosis. There are many things that can cause chest pain, but it is incumbent on any doctor that you see and you tell them, I've got chest pain, the first thing they want to rule out is your heart. Are you having like what we call, what's the common word, angina chest pain, or I don't want to use angina because that would be speaking medicine, but is it your heart? So that's probably what they did. That's why they sent you to go do the stress test. They have to rule that out, obligated to do that. But the most common cause of chest pain that we see, and there are many things that will do it, is GERD, acid reflux. It's burning chest pain from the stomach that comes all the way up the chest. It feels like burning. And it can be so bad and so uncomfortable. Usually, if that is the case, and we've ruled out everything else, such as your lungs, like a blood clot in the lungs, we've ruled out all those other things that can, like, your lungs may have even collapsed. If that has all been ruled out, okay, then we start looking at other causes. What other symptoms do you have? Of course, we can't sit back here and tell you what happened months ago because, we can't go back in time. But what you described sounds like acid reflux. And you ate. So my suggestion is when you eat, you said pounded yam, one of the things we recommend is not eating like within 2 to 3 hours of bedtime. If you go to bed at 10 o'clock, for example, every night, try not to eat anything later than 7 so that your food would really have gone down by the time you're going to bed. There are medications for this. And if you talk to your primary care physician, they can put you on it. Your cholesterol, we put people on, if you have high cholesterol, there are medications for cholesterol, but it depends on what the number was. There's bad cholesterol, there's total cholesterol, there's good cholesterol. There's usually a breakdown of all of that. And again, it depends. Is it familial? Is it something that's genetic? The treatment for that is different than if it is just, LDL, that's bad cholesterol that's really elevated. And they will calculate your risk factor for getting like a stroke before we put you on cholesterol. Does that make sense? On cholesterol medication.
3.5.
What is yours?
3.5.
What is 3.5?
Your bad cholesterol cannot be 3.5.
That's what the doctor said.
Oh, okay. Yeah, so, you took the test in America or in Nigeria? Yeah. Okay, so in America, in America, the bad cholesterol is LDL. That's the bad cholesterol. And by guideline, you want to have, the new guideline right now as we speak is everybody's LDL should be less than 100. In the olden days, it used to be less than 130. Okay? Now, less than 100 if you have no medical problems, which means even if you have high blood pressure, it's controlled. You don't have any heart disease, you don't have anything else going on. You want your bad cholesterol, which is LDL, to be less than 100. Some still go with the old criteria, which is less than 130. That's fine. But if you have a heart disease or any kind of coronary heart disease or diabetes, which is an equivalent of coronary heart disease, your LDL, the bad cholesterol, should be less than 70. So if you tell me your cholesterol is 3.5, I'm looking at it, I'm like, oh, I don't know, But by the way, the good cholesterol is HDL. And you want your HDL to be more than 40. So, that's just it. And if it's more than 40 and your LDL is less than 100 and you have no heart disease or any other medical problems, you're good. If you have a heart disease, like I said, it should be less than 70. So, but if you, again, I'm going by guidelines here, you can go wrong if you go by guidelines. There's a reason why there are rules and laws. You stay within the guideline, you'll be fine. If you have elevated cholesterol, according to the guidelines set by, the country and medical boards and what have you, but if you have high cholesterol, you've tried diet, you've tried lifestyle modification, you've tried everything, then I would hope that whoever is seeing you will put you on some kind of cholesterol medicine. I would hope. But like I said, if they're not doing what they need to do, then change your doctor.
But did they tell you specifically that your bad cholesterol is too high? And the other conditions that we mentioned, like if you are diagnosed with diabetes, that automatically means you must be on cholesterol medication.
Absolutely.
So, and we cannot tell you what to do because we don't have your health information. I don't have your chart in front of me. I don't know what your medical conditions are, because all of those things factor in. Your age factors in. So, you know, whether you smoke factors in. So those are all the things you should talk with your doctor about. There has to be a reason they didn't put you on cholesterol medication. There has to be. Nobody would just cavalierly refuse to give you treatment.
There you go.
Nobody.
So very quickly, just a word on diabetes. So, you know, the American Heart Association has guidelines that deals with how to treat patients that have had an heart attack or that have cardiac problems or heart problems, the ways to deal with them, how to manage them, medicines to put them on. Well, diabetes, unfortunately, is one disease that, for some reason, if you have it, it's a cardiovascular equivalent, which means that you can be normal. You may not have had any heart attack before in your life. You may not have had any medical problems before in your life. But if, for some reason, you're diagnosed with diabetes, according to the American Heart Association, your family doctor should treat you henceforth as someone who has had an heart attack or potentially would have a heart attack. So diabetes is a cardiovascular risk equivalent. So what you would put a patient on who has had a heart attack is what somebody who has diabetes should be on, even if they've never had any medical problems. And that's what the guideline says. So in which case, they need to be on cholesterol medicine. They might even need to be an ACE inhibitor also to protect their kidneys, you know. So.
Praise the Lord. So because of time and we have other sessions, we have a few other questions. So we'll try and cap this at 2 minutes. Someone has a question but wouldn't ask openly, and I'm sure a lot of them can relate to that. People want to hear some input on erectile dysfunction. So if you take Viagra, whatever, you take whatever, but people want to get some feedback on erectile dysfunction also. But we have other questions as well, so we'll try and keep that 2 minutes so we can move to other sessions as well.
So, erectile dysfunction. First question is, what's the problem? And I'm not asking anybody to answer, please, 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 please. I'm just saying the way I talk to my patients. Which part is the problem? Is it achieving an erection, or is it sustaining it? Okay? Because sometimes there are other things that can cause erectile dysfunction, such as psychological issues. You're stressed. And then in which case, when do most men tend to have an erection? When you're sleeping. Do you get an erection when you're sleeping? We ask all those questions. So again, sit down with your primary care physician. Medications like Viagra and Cialis are out there. But it's not, please, 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 don't randomly go and buy these medications because they're advertised on TV. Talk to your doctor, because there are things that go into prescribing those things. Do you have a cardiovascular condition, for example? Are you on a heart medication, for example, called nitrates? If you are, we can't give you those medications. Okay? There are other things that can be done. There are injections, which not commonly done, but urologists can give you an injection. They can do a penile implant. There are other options out there. But those are more invasive than just taking a medication. But if you are, please, everybody hear this. Do not go out and order Viagra or Cialis or whatever on your own without talking, please, 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 please. Because there are consequences.
I think the other thing I'll add to that is, erectile dysfunction is, the cause could be multifactorial. So there could be certain social lifestyle habits that someone may have that may be contributing to erectile dysfunction, and you may not even know. So that's why it's important to, if you're experiencing that in whatever shape or form, talk to someone to do a proper investigation to first of all identify, what exactly is the reason, if it's, something that needs to be corrected in a certain way from modification of lifestyle, or if it requires medical intervention before proceeding.
Okay, thank you. My question is there a best solution to anxiety? Because sometime in around April 2021, someone hit my car. Since then, I started having like anxiety whenever I'm driving. So I've gone through like this therapist for like a year, but still no solution. So I can't drive distance. I can't drive maybe like up to 2 to 3 hours because I still have this fear in me.
So he's talking about anxiety after being through a car crash. Is there anything to help him with that?
Obviously, I'm not a psychiatrist, so I'm not going to pretend to be one. So one, I would say, number one, we're in church and we're kingdom people. Let's pray to God. That's number one, what I would say we should do. Let's pray to God about it. Number two, I would say that medically now, you might want to talk to somebody, a psychologist, a psychiatrist, because it's been going, how long has it been going on for now?
2 years.
3 years, that's a long time. That's a long time. Anything more than 3 to 6 months is considered chronic in medical world. More than 3 to 6 months, it's chronic. You need to do something about it. So I would say, see a psychologist or see a psychiatrist who might probably give you some anxiety medications to calm you down. And because obviously in the last 3 years, I'm not aware that you didn't say that you've been hit by somebody else again. So it means that you could go for another 10 years without being hit by somebody, and yet you are still having anxiety. Perhaps it is possible that you may, I'm not saying, but you may have an underlying predisposition to have anxiety disorder. The accident just, triggered it. And now it's come to light and it's staying. So, two things. One, pray to God about it, strength. Like I said, we're kingdom children and we're in church. But also, two, make a frantic effort on your side to make sure that you see a psychologist or a psychiatrist who would actually perhaps give you medicine for anxiety. And I think you should be fine.
Yes, doctors, I want to ask you a question. There are some things in medicine that I think are like some objective suggestions in medicine at times are very contradictory because doctors at times contradict themselves. I lost my dad at the age of 87. He was never on any medication at that age. And my dad likes chocolate. He loves snacks and things like that. Could that be his body? And at times you hear doctors say, oh, don't eat this one, it's not good for you. Look, I've seen men, old men, even they even drink and smoke, and they're in their 90s, and they're like, Baba, at this age you are still doing this. I've been doing this from the age of 20. What are they doing that others are not doing? That is one.
That is a good.
I have to ask this because. Are you done with the question?
Yes, I need you to answer those questions.
All
because
right.
at times, sorry, hold on. At times, when people are sick, like somebody close to me was very sick lately. And one thing I learned from that person is, if doctors tell you have this ailment or that, you say the best medicine to any sickness is you being ready to be healed yourself. Just believe I don't have this thing. I'm not trying to be. I'm not trying to be religious this time around. But faith, just work in faith. Like yes, I read a book about someone that had cancer. When she was diagnosed for cancer, you know what she did? She resigned her job and started a business. And she focused on the business as if she was never sick. And psychologically, the lady got healed. Not through prayer or anything. But at times, you see, when doctors give names to all these diseases, you scare people at times. When you tell someone that you have cancer, they are dead already.
But Dr. Digbo has given us the question and the answer in one breath. But wait, we would have to let our doctors give us professional guidance.
Please, I don't know any doctor that will give you a diagnosis just to scare you. That is out of the question. Nobody will do that. And I've heard some of my patients tell me similar things. You know, my dad was a smoker, he lived to be 100 years old. Well, good for him, you know, good for him. You can blindfold yourself in rush hour traffic and run across the street and make it safely to the other side, safely. Does that mean we should recommend that for everybody? Okay? Smoking increases your risk of so many things. Lung cancer, like COPD, being dependent on oxygen. The fact that the odd person survives it, doesn't have any of those problems, doesn't mean that that is the way to go. Evidence has shown that you can't live like that. I would not recommend that for anybody. Anybody. There are elderly people who are not on any medications. So your dad, for example, if he lived in Nigeria, see, in Nigeria, somebody mentioned earlier, I don't remember who, that when we came here, we were skinny. And all of us packed on weight. It has something to do with what we eat at home, how active we are at home, which we are not here. We are really sedentary here. A lot of us just sit down at work. We get in the car, at home people trek. So there are a lot of things that go into that. So it's not like, oh, my dad lived like this and lived to be 100 years old, so maybe I should do that. I will make it to 100. No, I would not recommend that at all.
I just want to add also that I kind of lost my train of thought. Yes, I remember now. So please, if I tell my patient, this is faith, this is church, this is medicine, this is science, this is reality. Everything on earth came from God. Everything I know, everything I have came from God. My knowledge came from God. I owe it to God. But I also believe that God gave us the knowledge to benefit people. I have seen. I finished my residency in this country in 2007. I have some mileage under my belt when it comes to practicing medicine in this country. I'm a board certified in internal medicine. I work at Emory Healthcare here in Atlanta, Georgia. I have seen over and over and over and over again people that have simple high blood pressure. Just take your medicine. You will live to be 100. They refuse to take their. There was a lady who had a breast lump. This was a month ago. Had a breast lump, limited to the breast. 6 months before, the husband said they will pray about it. Patient comes back 6 months later with metastatic breast cancer to the lymph node. So I hear this all the time. People talk about this all the time. Like doctor said, there are people, you wouldn't believe it. They can eat whatever they like. They will still remain like this. Well, I think it was Pastor, or maybe Pastor, the other, what is John, that was talking about when God distributed talents, 5, 3, and 2. Well, that's their own luck with God. But that doesn't mean that would apply to everybody. Somebody else will smoke all through their life. Do you know how many patients I've seen with COPD huffing and puffing? And for every single one of them, if you ask them, any smoking history? Oh, doc, I smoke. Oh my God, 40 years. So it's not, 1 + 1 is 2. At least in America, it's 2. Because it's science. So I'm not saying faith does not work. That's not what I'm saying. But I'm also saying that every day I pray to God, God, keep my pressure down. The medicine I'm taking, please let it work. But I don't miss my pill every single day. So let's pray to God that we don't fall into the hands of doctors that will lie to us, but because there are. Let's pray to God that we don't fall into the hands of doctors who will do things to let us get money, make money. But if you truly, truly have an issue, if you go see a doctor, if they tell you this is going on, pray, but follow the advice. If you think that you are not happy, seek a second opinion. But please do not undermine the validity of one's situation, all in the name of, oh, somebody lived up to 90, didn't do anything, or by faith, So the person may have been healed of cancer. I do not know what happened, and they did their business. I don't know what happened. It's also very possible that they didn't have cancer at all, and they thought they had cancer, they were misdiagnosed. I don't know what happened. All I do know is that if there's an issue, let's address it, but continue to pray to God.
Thank you, sir. I'll just add quickly that, please, everyone, hear our hearts here. I think we're all saying the same thing. Hear our hearts. We sitting up here are Christians too. Think about that. I'm a physician. I believe that the blood heals. I believe in miracles. I have seen miracles. Yet I'm a physician. They are not necessarily mutually exclusive. But if your doctor tells you, oh, there is breast cancer or there is a spot on your lungs, let's check it out, please don't just turn around and say, I am healed, and walk away and never come back. Please. Did God lead you to that doctor, to that point in time to find that diagnosis? We have the knowledge for a reason. The knowledge comes from who? From God. So they're not mutually exclusive.
I think the final thing I'll add to that is, I think it's important for people to understand that when you see a doctor, the recommendations given to you is what we call evidence-based, which means that this is recommendations based on science and data that has been experienced in a lot of people, millions of people all over the world. So when you're given a recommendation by a physician, it's not really speculation, but this is evidence-based medicine. So it's saying, it's like, Dr. Lakin said, 1 + 1 is equal to 2. Now, are there going to be exceptions to that rule? Yes. I mean, same thing goes like, when you look at, even taking medications, side effects, even vaccines, when you take a vaccine or some medication, evidence-based will tell you there is a 1% chance that you may experience a side effect. And a lot of times we take those medications and nothing happens to you. But there's going to be somebody somewhere in the world that would experience a side effect. But because of that one person, does that mean everybody else should not take that medicine? No. It's all about risk versus benefits. And that's how you have to look at it. So when you're giving a recommendation, you may know 1 or 2 people that, they live their life doing things a certain way and nothing happened to them. But you look at yourself as an individual and say, that's an exception. What is the risk versus benefit for me here if I actually don't follow the recommendations my doctor has given me? And typically that would be detrimental if you don't.
Thank you so much. I have a question though, in the area of preventative medicine. Okay, so I don't know where I got this from, but I heard that when you take meat, you are at risk of having heart issues much later in life. I just wanted to clear that because each time I take a bite of meat, I remember. But I still go ahead and take it, but I just remember that. So I just wanted to clear, is it just a myth or are they correct?
So you are sort of kind of right, but it's red meat. red meat has higher fat content than, say, chicken. That's, I think I mentioned lean protein earlier when I was talking about the plate method. Lean protein would be stuff like chicken, turkey. What else is good for the heart? Fish, like salmon. That's really healthy. No goat meat, unfortunately, no. And I'm guessing we all love it. But no. And it's not just as simple as thou shalt not eat meat. You know, it's not that simple. What are the other factors in your life? You know, are you obese? Do you have hypertension? Do you have diabetes? Because you see, we keep coming back, if you've noticed, we keep coming back to diabetes and hypertension. We'll talk about everything else, we'll come back to those. Those are the two most common things we see. And I'm not asking for a show of hands here, please don't. If we checked everybody here, the most common thing we'll find will probably be diabetes and high blood pressure. Okay? And those are the things that increase your risk for heart, especially diabetes. Diabetes is an awful systemic disease. It's not just as simple as my blood sugar is high, because there are complications that come from diabetes, and I still haven't seen a patient who has uncomplicated diabetes. There's always a complication. It wrecks the kidneys. You develop neuropathy where you can't even feel your feet. Blindness is systemic, and it increases the risk. Like Dr. Lakon said earlier, cardiovascular risk equivalent means that if we diagnose you with diabetes right now, we assume that you've had a heart attack. It will treat you the same way as if you've had a heart attack. Okay? That is the more important thing. But dietary modification, as we talked about earlier, leafy green vegetables. Yes, cut down on the red meat. It doesn't mean don't ever eat it at all. Okay? But if you want to eat goat meat or beef, once a month, once in 2 months, yeah, but make your diet more of the leafy green vegetables, the complex carbohydrates, and the lean protein like salmon and chicken.
And I think one other thing I'll add to that is having a lot of meats, or especially red meat in your diet, with less vegetables or less fiber in your diet, could also affect your colon in the long run. So I think as men, you have to be vigilant about your colon health. And it's not just colon cancer. There's a whole bunch of other things that can happen with your colon, especially once you get to 40 years and above. So it's very important to have a lot of fiber and vegetables in your diet and cut down on meats.
Thank you very much. I have a quick observation and comments. I know that recently, from my workplace and also from all the other activities I've been doing, there has been a lot of trend towards mental illness. And I know there's this stigma about us from, I would say, Africa or big men, that we don't want to talk about that. What are the ways, especially in our fellowship here, that we can start talking about mental illness for men? A lot of our males, we go through a lot of stress. We work, we try to think about Nigeria, we try to think about home, and a lot of us are going through mental illness that we just do not want to talk about. What are the plans, or what are the ways we can start creating awareness and finding a way for men, especially, to be thinking and be figuring how to deal with that? Thank you.
I just want to add quickly that it's been a great session. We have other sessions waiting on the back of this. So we're going to take just one or two quick last questions, because we have to really move to the next sessions. Otherwise, what I like that the men have actually opened up to talk about their health. So it's a good thing. We're all learning quite a lot here today. So, but at some point we have to stop the party. But we'll take one or two more questions after that one. Okay. Please, you can respond to his question.
So I think that is a fantastic question. You're correct. Mental health is something that we don't talk about, even in America as a whole, let alone in our community, considering where we came from in Nigeria, whereby people automatically assume if you have mental health, you're crazy, you're mad, and nobody wants to talk about it. But I agree with you, sir, that we should be able to figure out a way, particularly in our community, to imbibe the current trend and understanding in America. After all, we live in America, right? And we are, first of all, Americans of Nigerian descent before anything else at this point in our lives. So, specifically in the church, again, we're in the church, so an individual who may think or think they're having mental strain, there are two ways we could deal with it. The men as a whole could find Pastor, I don't know Pastor's name, but Pastor is here. Pastor Fred? Yeah. Yes. So, for example, Pastor Fred is here. Pastor John, I don't know if he's here. These are men of God that I believe that we should, and Pastor is there too, Pastor Joe, Oga at the top. I want to believe that we should cultivate a habit where any one of us having such a mental stress should be able to go to these people. And the reason why I am leaning towards them, it's because of the confidentiality mandate that will be upon them as pastors. Now, that does not mean that if an individual finds anyone amongst us as a good confidant, then the person will have to be the judge of that. I'm not saying pastor because they're already pastor in the church anyway. Then go to them and talk to them, and then, see how they can help you with what the issue is at work, what the stress is at work, and perhaps they may even pray with an individual, and if it's something that a session needs to happen like this, why not? Why can't we have a session on mental illness? Why can't we have it? The president is here. The leadership of the Men's Forum are here. I think it's a fantastic question once again because we often don't talk about that. So why can't we have a session on mental illness? So I would say let's approach the pastors, confide in them, talk to them, and approach whoever else we think we can confide in. But then we can have a mental illness session and help each other out.
Yeah, so I think I like the mental health illness kind of day or something like that. Because, especially coming from the Nigerian community, there is a lot of people, it's a lot of men that are exhibiting symptoms of, mental strain, but don't even know. And sometimes people around them may not even know. You could have friends that are exhibiting symptoms of, behavioral disorders, but sometimes we may look at some of these things as normal. So I think the first thing is there has to be an awareness within the people of what are the signs, what are the telltale signs of mental strain, mental illness in people. And sometimes it's so subtle. It's not necessarily like where we come from in Nigeria, like someone being mad on the street. No, there's subtle symptoms that sometimes we see every day and we think it's normal, but it's not even normal.
Good afternoon, gentlemen, and thank you for taking time to answer our questions. My question has to do with low dosage aspirin. If it's advisable to take or if it's something you have to have a discussion with your PCP.
Simple answer. Talk to your doctor, your primary care physician. Please don't start aspirin just for the sake of it. There are reasons that people are put on these medications. Like if you've had a heart attack, if you've had a stroke, if you've had a stroke, for example, they will put you on aspirin and another medication called Plavix, then they would drop one of them. If you had a heart attack, they will do the same thing. So there are reasons for putting people on these medications. And the one thing that this question has prompted me I forgot to say this. A lot of my own patients that I see do Dr. Google and try to practice medicine. Believe me, there is too much nuance in in medicine for anybody to just sit around and Google it. Too much. So please always talk to your doctor, always.
So when it comes to low-dose aspirin, and by the way, low-dose aspirin means that you're taking 81 milligrams of aspirin. So there's 81 milligrams, there's 162 milligrams, and there's 325 milligrams. 325 milligrams typically for anyone who's had MI and what have you. But low dose aspirin, 81 milligrams. When I was doing my residency in 2004 to 2007, the guideline back then was anybody above the age of 40 should take 81 milligrams of aspirin for what is called primary prevention. Just because we are getting older, our blood, whatever, risk of stroke, risk of whatever, get on 81. And back then, anybody who was above 40 used to be on 81 milligrams of aspirin. Well, over the years, they found out that a 50-year-old guy who is normal and started taking 81 milligrams of aspirin for primary prevention for the last 10 years is walking down the aisle, falls down, and then bleeds. Why? This guy has been normal all his life. Well, this guy has been taking 81 milligrams of aspirin for the last 10 years because of primary prevention guideline. And that is the reason why the U.S. task force, which is the most powerful, underline powerful, guideline recommending body in America came out last year, I think, last year or year before last, and discontinued that guideline. No more 81 milligrams of aspirin for primary prevention for anybody above 40. It has to be patient specific. So just because you're above, no, don't take it. Now, if you have a heart problem and your doctor says take it, take it. So the answer to the question is no more 81 milligrams of aspirin for anybody above 40. It is patient specific. Talk to your doctor. Depending on your medical situation, they will say yes, they will all say no. I took it, I stopped it. So.
Last question. Thank you very much for the panel. Since a lot of the people who come to you, they have hypertension, how do you distinguish between the patients who have salt-induced hypertension, it's genetic, because a lot of us eat with a lot of salt, and a lot, some people cook a pot of soup, they'll pour like 100 Maggi's inside, put salt, put everything, it's so salty, and a lot of, black people who cook with salt, go to Jamaican restaurants, and it causes salt-induced hypertension. I think you mentioned DASH diet and how to reduce. So how do you distinguish when you put somebody on medication, and you tell them to change their diets to wean them off of medication? Just like Dr. Jibo said, if you take your high blood medicine on a regularly, so how do you know if it's salt-related, and do you tell them to reduce the salt, and how do you recommend us to start cooking with low salt, especially?
So there are two things going on here. The most common form of hypertension we see is what we call primary hypertension or essential hypertension, which is we don't know the cause. The cause is more than likely, we assume, that as we age, there's the coarsening, the hardening of the blood vessel, the arteries, and that is what causes the hypertension. That is the best explanation we know for now that science has given us. It's not salt. When you say salt, what I think of is what we call hyperaldosteronism, which is secondary hypertension. And even so with that, it is the hormone that, that controls the resorption of sodium, salt, back into the blood. And if you have too much of it, well, it will increase your sodium absorption in the kidneys, and guess what happens? Water follows sodium, and therefore blood pressure goes up. But that is not very common. The salt we were referring to is if you have been diagnosed with hypertension already, well, you may want to cut down on your salt intake. Like we said, the DASH diet. The other thing is that we don't do the DASH diet. I think I wasn't clear. We don't do the DASH diet or decrease salt intake so that we can wean you off the medication. We don't plan to wean you off your medications. We want you to stay on them because you are going to need them. And I have seen patients who said, well, I was watching my blood pressure, I was taking it, my blood pressure was fine, so I stopped taking my medication. Well, guess what? Your blood pressure went back up. What it means when your blood pressure is within normal limits, when you're on these medications, is not that you've been cured. What it means is that the medication is doing its job, and you need to stay on it.
Praise the Lord.
Please, let's put our hands together for our men. I think it's been an awesome session. We hear you. We need to have a session on mental health. I think we have a few people in the house, Dr. Rolake. So we have a people that can do that. We didn't touch on prevention today, which we know is actually the best form of anything else. It's cheaper and it's safer. So we're going to have a session to touch upon, preventive health as well as probably mental health as well. But just to allow us move to the other sessions for today, I'm going to call on Dr. Jide. Let's put our hands again, for our doctors in the house. Thank you.
Thank you very much. Thank you, gentlemen. That was awesome. And hey, were we blessed? Okay, great to know. That was pretty productive. One of the things I was going to add to, literally everything is, as individuals, pay attention to yourselves. Pay attention to yourselves. It's all about what is new, what is a trend. Someone says, hey, I have a very high pain threshold. But what you're experiencing now, is it any different from what you used to have? Is it any more frequent? I pee a lot at night. Is it any different from what you used to have? It's about what is different, what is trend, what's a new trend. Pay attention to yourselves. We're going to move straight on to the business and the investment part of our session this afternoon, and I have where's a good place to stand rather. I have an army of very, very, good people, knowledgeable industry experts that are going to be helping us this afternoon. So please, as I welcome each one of them up here, please let's give them a round of applause. Appreciate them. If you enjoyed the first session, we're even going to enjoy this one even more. So first, I am going to bring up for the next session, Barrister Akin Doherty. Is Akin still here? Oh, please put your hands together for Mr. Akin Doherty. He's going to be talking to us about business registration and the likes. Yes, thank you very much. Business registration, business opportunities, and the likes. We also have Mr. Paul Totman. Paul, please put your hands together for Paul. Hi, Paul. Welcome. So Paul is a mortgage loan officer with PNC Bank, and he's going to be talking to us about mortgages and mortgage opportunities. We have Mr. Sunday Okechukwu in our midst as well. And Sunday is going to be talking to us about business loans, account openings, business opportunities. We've had an opportunity to work with Paul in the past, an organization that I belong to. And Sunday has a 12-year experience in banking. He worked with Bank PHB in Nigeria, if anybody knows Bank PHB, and then moved over to Bank of America and Trust Bank, or Truist Bank, but he's now with PNC. So a lot of experience to glean from here. And then finally, someone who's going to be talking to us about 401k and other investment opportunities. When I call his name, you'll see that he's a repository of a lot of information. Please, again, let's put our hands together for Dr. Lekon Jibowu. And Dr. Jibowu is going to be moderating this session. Good, good, good. Well, I truly want to sit down for this one. All right. Okay.
Good morning, everyone. Oh, I think you're sitting down here. Oh, okay. Good afternoon, everyone, once again. So, my name is Dr. Lekon, and I'm happy to be here, and I'm thankful to the leadership of the Men's Forum, giving me the opportunity to moderate this segment of the conference. So at this time, we're going to be talking about wealth building, and I'm thankful to our friends, our guests from PNC Bank that have come out to enlighten us about building wealth and give us pointers to what we need to do to build wealth. I'm going to be sharing my own humble opinion about wealth building and what we need to do. So, it's a good thing to build wealth. You know, we create wealth, we build it, we grow it, we sustain it, we protect it, and eventually we pass it on. I always say to people that any wealth dream that anyone has that you don't get to pass on to your lineage is not big enough. Before I hand over the mic to our guests, I just want to say one or two comments. There is a clear distinction and a clear difference between acting rich, looking rich, being rich, versus being wealthy. They're two different things. And two different things. Well, no, there's one column, acting rich, looking rich, being rich, that's one column, versus being wealthy. Any individual can look rich. Any individual can act rich. Any individual can be rich. What that means is that perhaps such an individual is making good money, making a high income, perhaps from an employed position, or even from a business, or whatever way they are making their money. But it also means that they are probably just spending it buying stuff. That is completely different from somebody who is wealthy. In which case, such individual has saved up assets. It could be in form of stocks, it could be in form of bonds, it could be in form of real estate, or whatever else you want to do. And the good thing about this part of the equation is that not only do these assets grow in value over time, because they do grow in value, they at some point in time in the future begins to give return to the owner of the assets, either by way of cash flow, if you're in real estate, by way of dividend, by way of interest, even by way of inherent equity growth in the value of such assets. You know, there's this lady, Sarah Blakely, the founder of Spanx. She's worth over $1 billion. She talks about the concept of people building a portfolio in the stock market to the point whereby the portfolio begins to give such an individual income. Okay? I think about this great real estate investor, Grant Cardone, who is worth over $600 million right now. He talks about building a real estate portfolio to the point whereby the cash flow from the real estate, you know, equals or even surpasses an individual's income, at which point in time you can begin to look at yourself as being wealthy. And of course, as we all know, the great Warren Buffett talks about if you are an individual and you cannot make money while you sleep, then it means you're going to work until you die. You know, so it is important for us to have a clear-eye view about where we are putting our money. You know, Rich Dad Poor Dad, Robert Kiyosaki talks about liabilities on this side and assets on that side. And the simple way to see it is this. Asset puts money in my pocket. Liabilities take money out of my pocket. Wealthy people put money into things that put money in their pocket. Not so wealthy, though, put money into things that take money out of their pocket. So it is very important for us to have that clear view of how, being rich and being wealthy works. So having said that, I don't know who would go first. In what order are we going?
I guess I can start.
Okay.
I mean, just to piggyback from what you said, the one thing I would say, as an attorney here, that, I do a lot of trial stuff, and in my years, I've represented a lot of business owners, represented a lot of people. One thing I would say that it's a common mistake that people make is that, first of all, everyone is a walking business. Thank God for, in the United States. You don't have to, first of all, set up a business officially to be a business. You are a business, and it's called the sole proprietorship. That is a default business. You can still itemize deductions on your taxes if you're a sole proprietor. So you don't have to have an official registered business. The only things that will register business